So our next session is our plenary session on universal health coverage. And I would like to introduce our moderator for this session, Professor Chantal Herberholz, Faculty of Economics at Chulalongkorn University in Bangkok, Thailand. So Dr. Chantal Herberholz is Associate Professor in the Faculty of Economics. Just goes to show you how very interdisciplinary global health is. At Chulalongkorn University, Bangkok, Thailand, she has served as the director of the faculty's Center for Health Economics, a WHO collaborating center, and a member of the Asia Pacific Network for Health Systems Strengthening since October 2017. Her research interests are in the areas of healthcare financing, health and household decision-making, and trade in services. Thank you so much for moderating our session.
Hello, good morning. Thank you very much, Melissa, for the kind introduction. And I would like to warmly welcome all of you to the APRU Global Health Conference 2020 plenary session on universal healthcare coverage. For those of you who joined later, let me just repeat once more that this conference is organized by Fudan University and the APRU Global Health Program. We would also appreciate it very much if you could share the conference on social media. Thank you very much. Today, we are honored to have two very distinguished speakers on the panel. The first speaker is going to be Professor Jun from the School of Public Health, Peking University. And the second speaker is Professor Chan from the School of Public Health, Fudan University. So let me just explain the format of the session. So each presenter will have 13 minutes. And after these presentations, we're going to have a 10-minute Q&A session. So I would like to invite all participants to raise questions using the Zoom Q&A function. Now, please allow me to introduce the first speaker, Professor Jun. Professor Jun is a University Chair Professor and Head of the Department of Global Health at the School of Public Health, Peking University. He received his medical education and training from Shanghai Medical University and his MPH and PhD in epidemiology from the University of North Carolina, Chapel Hill. Professor Jun holds leadership positions in a number of professional organizations. His current research focuses on 4 areas, one of them being epidemiology and prevention strategies for diseases of major public health concerns. The second field being emergency medical system development and policy, then also public health emergency preparedness and responses, and last, global health strategies and governance. Today, he will talk about the quality of care and universal health coverage, convergence for resilient health system. Professor Jun, please.
Thank you, Professor Herberholz. Let me come my. All right. Well, very delighted to be here and to share my thoughts on quality of care and universal health coverage in relation to resilient health system. And really very, very delighted to be on the panel with Professor Chen Wang of Fudan University. And also very delighted to hear keynote speak earlier. And this is really wonderful in the shadow of COVID-19 global pandemic. I think more than ever that healthcare system strengthening is one of really important topic And particularly when we talk about the terms of quality of care, universal health coverage, and resilient health system, this are all related to our current situation. And so, as we all know, that universal health coverage really aims to provide health security and universal access to essential care services without financial hardship to individual, family, and community. Thus, enable a transition to more productive and equitable society and economy. And evidence has really suggested that suboptimal care wastes significant resource, sometimes even harm to the health of the population. So quality health care issue really, when we talk about coverage, is more on the access, but the delivery side is also really, really important. It not only prevent human suffering and ensure a healthier society, but also to ensure a better human capital and a healthy economies. That's really important when we talk about the global pandemic. So quality care issue and especially patient safety, really is essential to create a trust in health system. It's also key to global health security, and in turn will depend on the high quality frontline health services. So what is the quality of care? Quality of care is really the degree to which health services for individual and populations increase the likelihood of desired health outcome and are consistent with current professional knowledge. So maybe it's a different time when we define quality of care. So make sure that in the definition, we do have a sentence called are consistent with the current professional knowledge, which right now we define sometime in the evidence-based medicine or evidence-based guideline. So many of those measures include effectiveness, safety, efficacy, timely, or accessibility, sometimes also including the part of quality of care. And equity access, equity across population is also one measure of quality of care. And other measures such as patient centeredness, and also minimize the resource waste. So there's many examples that relate to suboptimal healthcare quality. For example, side effect, hospital-related infection, and disparity in healthcare provision and delivery, and also the disparity in vaccine rates, and many of those issues. Well, I want to raise one study which published in 2018 in Lancet. Really look at mortality due to poor quality versus non-utilization of healthcare by condition type. If you look at the cardiovascular disease on top of the chart, well, really the poor quality. That means that it did not adhere to evidence-based guideline, plays a huge role in terms of mortality compared to non-utilization. The others, like neonatal death, tuberculosis, and others, you can see the significant attribute to poor quality in terms of mortality. And if you look at the mortality due to poor quality of healthcare by country, there's a huge disparity. The significant, we can see in African countries and also in South Asia and other countries. There's a very, very significant problem in terms of mortality due to poor quality. So WHO, working with World Bank and OECD, published an important document in 2018. It's called Delivering Quality Health Services, a global imperative for universal health coverage which really emphasize the quality of healthcare issue and how we should incorporate the quality issue into the universal health coverage. And also there's a companion handbook for national quality policy and a strategy. So these are very important documents. I will encourage you to check with the WHO website and download the report and have a look at that. And also the US National Academy of Medicine published a report on closing the global quality chasm, really look at the structure issue, process issue, and outcome issue, and focus on the WHO health system building blocks that including service delivery, health workforce, information system, and access to essential medicine, finance, and leadership and governance. And in terms of process, both in patient side, microsystem organization, environment side, and also look at the outcome of care. These are important reports. I think that really outline the problem and also potential solution for that. And from WHO report, I think that this is really important that we need a national quality policy and strategy, including 8 elements that including national health priority, local definition, stakeholder mapping, engagement, situation analysis, governance, and improvement methods, and of course, important for information system, the quality indicator, how we can really build this environment of continuous quality improvement process. And of course, the important that we really need to have a better skilled health professional who are really important in terms of healthcare quality healthcare delivery. And if you look at the global issue, we still have a huge problem in terms of skilled health professional. So that's really important for a university like APRU membership, that we are at the front line of educate and health professionals. So this is really important. Of course, healthcare, primary healthcare as a hub for coordination should be emphasized. And in many countries, I think that strengthening a primary care system is a way of improve the quality care. And in terms of intervention, we can have a different level of intervention at the government level, at healthcare facility level, at the clinical providers level, and also at patient and public level. So all these intervention has been in many intervention has been tested, and if we look at the literature, there's many information. One, of course, what I would like to raise, like American Heart Association, Stroke Association, focus on quality and together with guideline, and the others were disease-specific issues that measure outcome and improve care and save life. I just want to share some of the information that over the last 5 years, the Heart Rescue Program that we work with Electronic Global Health Foundation, and in 4 countries, and including China, India, Brazil, and the United States, and working with partners that we have developed the implementation research. We will look at based on the evidence-based guideline and the recommendations, how we can really using that and implement those intervention and measures in the community in China, in India, and Brazil. Really break down the barriers and implement a specific intervention. So this is the target. Were really the objective was to improve the access and the quality of care for people with severe heart attack, also known as ST elevated myocardial infarction or STEMI. So the goal was the issue that we have seen the increased burden of cardiovascular disease worldwide, not only in developed countries, but also in low and middle income country. The timely evidence-based standard treatment with reperfusion really improves the survival and reduce disparity and lower the cost. So we're using these specific measures and target at the community, EMS, and hospital, and to make sure that the patient receive timely care. But also we measure all steps in the process about timing, and so the result of that, certainly we will see the community impact and the community member train and high school student reach, the family member train, and also we will see the improved measure in terms of percent of patients arrive at the hospital by ambulance instead by walking, increase from 0% to 48% in India, and also number of calls for chest pain to the emergency telephone number increased from 35 to 90 per quarter in Brazil. And we also see the impact in EMS and the hospital impact, and those are really critical to a quality measure. And certainly, we also learned a lesson from this study that we will see huge disparity, gender disparity, that access for women is quite low in all countries, and the training for health worker is valuable, but the retention is really a challenge, and the data issue is also a problem, and the healthcare system is also a huge issue for us. So I want to share that by quote Dr. Tedros quote about this issue, and there's no universal health coverage without quality care. Improving the quality of care is a challenge for all countries and all health system. So this is the end of my talk. Well, thank you so much.
Thank you so much, Professor Chen, for this inspiring talk on quality of care in the context of universal health coverage. It is now my pleasure to introduce the second speaker, Professor Chan, Director of the Center for Pharmacoeconomic Research and Evaluation, Fudan University. Professor Chan received his MD degree in social medicine and health management from Shanghai Medical University in 1998, and he completed a research fellowship at the School of Public Health at UC Berkeley. Professor Chan is often invited as investigator and advisor by national and municipal governments for various research programs in the field of Chinese healthcare system, national and provincial health insurance, pharmacoeconomics, and pharmaceutical policy. He has more than 120 publications in international and Chinese health economics and management journals. So today he is going to share the talk on co-construction and sharing to achieve universal health coverage with us. Professor Chan, please.
Thank you very much, the moderator, Professor Chanto. Good morning, dear colleagues and students, ladies and gentlemen. I would like to introduce you the China case on the topic of co-construction and sharing to achieve universal health coverage. With the economic development, China has made great progress on health development. Health status of Chinese population in terms of child mortality, denoted by the line with white points on this figure, has improved significantly in the last 50 years and close to that of the developed countries. It's demonstrated that this achievement can be greatly attributed to the strengthening primary healthcare organization and construction, emphasizing disease prevention, organizing larger scale mass health campaigns, and establishing a low-level, wide coverage urban and rural basic medical insurance system. However, there were still many problems on health system of China, which brought about a new turn of healthcare reform since 2009, aiming at the establishment of an upgraded basic healthcare system, adapting to socioeconomic development and population health needs by 2020. This health reform plan covering a very comprehensive contents, including the medical services system, public health services system, medical security system, and pharmaceutical supply system. And a series of reform measures focusing on administration, operation, financial input, price management, to supervision, science, technology, and talent development, health information, and legal system have been implemented to facilitate the establishment and the development of the above four systems. As one of the most important actions, government spending on health has been increased. Firstly, it was employed to deliver equitable public health services according to a core package defined as basic public health services, free for all residents, and the major public health projects, including infectious diseases prevention control, and important public health interventions such as immunization in hospital delivery. Secondly, increasing financial subsidies of government have been used for the urban unemployed and the rural farmers for their enrollment in basic health insurance schemes. More than 2/3 in total contributions came from the government, greatly increased from the original 20 renminbi for farmer in 2003 to no less than 550 renminbi per instilled in 2020. And the government investment has also inputted to government-owned health institutions for infrastructure construction, subsidies for personnel salary, and specific reforms. And also medical education and research were also furthered by the governments. On the other hand, a new health insurance system has been remarkably established in the last 20 years. As this slide showed, the medical insurance scheme for urban employees was launched in 1998, which marks the beginning of the social health insurance system in China to replace the previous government and enterprise-based welfare programs. And then the medical insurance schemes for urban and rural residents subsidized by the government investment, as mentioned above, were developed in 2003 and 2008, respectively, and integrated into one single scheme at prefectural level in 2016. In addition, another medical insurance scheme for catastrophic diseases has been introduced to improve financial risk protection of residents' medical insurance schemes. And the long-term care insurance was piloted in select cities to meet elderly demand for nursing care. With the development of the medical insurance system, the population coverage of basic medical insurance has been greatly increased to over 95% in 2010s, as this right graph showed. Meanwhile, purchasing function of the medical insurance schemes has been strengthened, including benefits package extension based on health technology assessment evidence, DRG system adoption, and the bulk procurement of generics and medical device to raise the overall efficiency of the medical insurance systems. And now, there is the obviously change of structure of total health expenditure to reflect the impact of financing reform of China. The share of out-of-pocket payments has significantly decreased from over 40% before health reform to lower than 30% in 2018. And meanwhile, the proportion of social health insurance in relatively to total health expenditure increased from 33% to approximately 40%, while government spending on healthcare delivery remained stable during the same time period. On the supply side, a lot of changes have been made to improve efficiency and quality of healthcare delivered. A people-centered integrated care module has been initiated in recent years. Before that, primary healthcare combining preventive and public health services and clinical care has been strengthened for a long time. And the vertical integration of different levels of medical services has also been encouraged to promote care continuity and capacity building of lower level of medical institutions. And the new integrated care system is still in progress and needs further organizational and policy innovations. The access and rational use of medicine as one important areas receiving considerable attention has been improved through removing reverse incentive for overuse of medicines. That is the implementation of zero markup policy between wholesale and retail prices within public hospital and primary health institutions. A new market-oriented pricing management, monitoring and the treatment of clinical shortage of medicines, and the prescription audit and the guidance for rational use of medicine has been adopted. Last but not least, public hospital reform has been piloted on governance, internal management, and compensation change. The evidence showed that the financial risk protection has been greatly improved in either urban or rural areas and groups by household income. In terms of the proportion of household with catastrophic spending, health spending, although the gaps still exist between urban and rural areas and among different socioeconomic groups. The most significantly improvement has been observed on the most vulnerable groups of the first quintile of household income. Based on the brief introduction of the above progress in China, here are some experience to achieve universal health coverage, maybe available for other economy. Health development should be prioritized by government commitment and followed by continuous government investment on health and reform leadership to mobilize all related government departments, stakeholders, and the public to be engaged in achieving universal health coverage. Emphasis should be put on the system development and incentive innovation, especially coordinated development of medical insurance system, and healthcare delivery system. Local pilots can inform policy formulation and implementation, scale to the national level. And health reform should adopt a systemic approach that aligns multiple policy levels, such as financing, provide payment mechanism, governance, and regulation. So China is still confronting challenges and problems on health system with the socio-economic development and population aging. As designated by the Healthy China 2030 strategy, health is a necessary prerequisite for the overall development of the population, as well as the foundation for the sustainable development of the society. So China will continue to work hard and make contribution to global health development. So that's all. Thank you very much for your attention.
Okay, thank you very much, Professor Chan, for this very interesting talk about China's experience with UHC. Now, before we start the Q&A session, I understand from Melissa that there is a question in the chat box that we would want you to vote on. So if you could please have a look at it and then cast your vote, and we'll get back to it later on. Thank you. We've had a couple of questions in the Q&A box. So let me start with some of the questions. And if I may, I take the first question from Haytham Shearer. And it's a question for Professor John. So here the question is, in your opinion, how would the index of effective coverage of health services look if the direction of accountability was shifted to people in the countries, users and non-users? Thank you.
Well, this is a very good question, excellent question. I think that the access to care, well, that's we're talking about universal health coverage that first probably address more on the access issue. I think that in the future, when we really dealing with healthcare issue, we need to also have discuss and address the delivery issue. And so this is really not too much about patient. Well, patient also really important, because many think that the access started with patient, and delivery, of course, is also issue that evidence-based medicine and guideline and how adherence to clinical guidelines is really important for a healthcare system to make sure that those guidelines will be used, and physicians and providers adhere these guidelines. And in our case that I present was really we measure patient from onset of chest pain, and to whether patient call the emergency number, and whether the emergency ambulance arrive and into the medical system. So every step we time those steps, and this is really important. And very often that, particularly in the case of acute cardiac care, because time is really very important. So as a stroke, and the time is muscle, time is brain. So every minute of time pass, we're talking about 10% of survival decline. So those issues are really important. If system is not there, we don't have quality. So both every aspect of system are really including a patient, the public, and also a physician in the system.
Okay, thank you very much. Let me now just pick a question for the second speaker, Professor Chan. Here's a question from Mohammed from Khartoum University in Sudan. And he would like to know what are the current challenges to achieving universal health coverage? It's a very broad and difficult question. Professor Chan, please.
Yeah, thank you very much for this good question. So at the universal level, now we have a different aspects for the coverage. One is the population covered by the medical health insurance schemes. And second is the services coverage. So maybe a core medical services package and also public health services will be provided by the basic health insurance scheme and the governments. And the gap still exists between different different population groups covered by different basic health insurance schemes. But for the public health services, that's equitable for all Chinese population. So for the specific treatment therapy, so depends on the patient's diseases and whether where the patient will go to, maybe at a primary healthcare institution, they will get the basic medical services and a package of the public health services. The user fee will be relatively lower. And when the patient goes secondary or a tertiary hospital, they can have access to high technology treatment, but relatively high out-of-pocket should be paid by the patients themselves.
Okay, thank you. Another question for Professor John, please, from Unami Japta Malandu. And the question is a straightforward one. How do we incorporate political leadership in global health?
I'm sorry, say it again.
Okay, so the question is, how do we incorporate political leadership in global health?
Well, certainly, this is a really good question. And I think this time, the global pandemic of COVID-19 really helps in many ways. In the past, it's kind of difficult to persuade or advocate for global health for political leaders. And in many countries, in the developed countries, and people were wondering why we need to do global health. And while U.S. National Academy of Medicine and previous IOM has published a report saying that while U.S. commitment to global health is really a national interest to the United States. Same thing for China, while we are in many ways we try to persuade the political leaders of why global health is really important. Particularly in China, we have a huge domestic issue, and why should we focus on domestic issue first? So this is universal for every country while political leader face this issue. But I think that from this COVID-19 global pandemic, I think this is a vivid example for political leaders say that if we don't work together in global health, we will face the consequences. And so in many ways, this is probably the positive impact of this pandemic. But I think that for academic and for global health professionals, we really need to advocate and really to discuss global health issue with the political leader so they can understand the problem, why each country, why we need to take global health seriously. Thank you.
Okay, thank you very much. I know we are running out of time, but I would like to pose one last question to Professor Chan. And this is from John Patino Rueda from Colombia. And the question is, in Colombia, we have many problems about the vertical integration in the health system. What is China's experience with vertical integration?
Probably, excuse me.
Okay, so
Problem.
repeat the question, Professor Chan. It's a participant in Colombia, and he's basically saying there are many problems with vertical integration in the health system in his home country, and he would like to hear from you about China's experience with the vertical integration in the health system.
Well, yeah, actually, I have no specific understanding of these very specific fields, but I would say maybe we have a different difference between the China and Colombia. So many experience and the lesson from China will be available for your considering for the reform or the change and innovation in very specific fields. So maybe I hope later I can provide more information on these fields to you.
Okay, thank you very much. And we are running out of time, so let me just express my heartfelt thanks to both speakers, Professor Chen from Peking University and Professor Chan from Fudan University. I would also like to thank the participants for taking part in this session. I very much appreciated your questions, and I do apologize. There were several questions that could not be taken due to time limitations. And I'm sure either the speakers or the organizers will get back in touch with you later on. So we are now going to have a short break. And I understand that we will be back at about 10:55.